Well, good afternoon, everyone. My name's Justin Groden. I am a heart failure cardiologist. I'm a clinician, like maybe many of you. I'm at the bedside, and also I'm an associate editor at Circulation, and I largely handle the mostly clinical papers. So really the goal, well, first of all, I want to thank you all for having me here. This is a tremendous opportunity for me, and I've been delighted to meet all of you and to participate in this. So without further ado, really the goal of this discussion is not to go over a lot of content. It's really to give you some examples of clinical papers that we accept. So my talk is actually relatively brief. For the next 5 to 10 minutes, we're going to discuss some qualities that we look at in papers, and then I will give you some examples of clinical papers that we accept. And some might surprise you, but this should give you the framework to hopefully stimulate conversation and discussion when we have our Q&A, which should hopefully be a really engaging time for those of you in the audience. So when we're looking at clinical papers, we have really 3 general concepts that we look at when we're assessing the value of a paper. So those are, what is the paper's impact? What is its validity? And then very simply, what is the degree of readability? So now when we're talking about impact, that comes in several different flavors. And I'm going to go through each of these questions, at least how we think about it on the editorial board. So the first is, what is the knowledge gap? What is the importance of knowing this? What gap are we filling? What is this unknown? And then how will these data or how will this analysis inform how we think about something? And then very simply put, we're all clinicians, as Dr. Hill had highlighted to you, and we do have a clinical flair for our papers. So what are the implications of this research? How will this change the way we view patients, the way we think about a disease, or how might it impact how we treat someone or think about their prognosis? And then also in impact, we assess what are some novelty, and so what are unique and novel aspects of the research. So when we talk about this uniqueness and novelty, this doesn't have to come in some, very unusual or very rare disease, right? Something novel could be novelty in methodology. It could be unique in the patient population that's selected. Maybe, you're following the world's largest population of a ultra rare type of vascular disease. So there was one paper we had published and we're very excited a few years ago. I'm not going to show it to you today, but to give you an idea of 25 individuals that have this rare accelerated aging syndrome, and they all get very early vascular disease. So we thought that was highly impactful, and it only had 25 patients. So novelty and uniqueness can come in a variety of flavors. And then one of the things that Dr. Hill and the rest of our colleagues on the editorial board harp on all the time is this manuscript and is this work valid? So what do we mean by that? Are the results robust? Does everything they show, does it support the conclusions they're trying to make? So if you have a primary outcome that's positive and it's supported by all the secondary outcomes that are going in that direction, that would be an example of something that would be a very robust finding. And then, of course, are the statistical methods appropriate? So some of us have different levels of statistical expertise. For papers that we really like conceptually, we have formal statistical editors. But again, this folds into the validity, right? Is the analysis believable? Are the results believable? And this folds into that. And then lastly, is the study adequately powered? So I think that one speaks for itself. And then readability, I think this is quite straightforward, but is this clear and concise, right? So do we get the idea? Can we extract the information quite readily, or is it quite cumbersome in text? Is the text understandable? And then is it visually accurate? And obviously, it helps when all the figures are appealing. So with that framework, I'm going to show you just 2 papers that we really liked. One is a clinical trial, and then another is an observational cohort study, which many of you may do in your own work, that we thought was a very important manuscript, and we had it in high regard, and we moved forward with a publication in Circulation. So, a quick bias, I'm a heart failure doctor, so you guys are going to get stuck here seeing 2 heart failure papers. So this is a study out of Germany. This is called the MPAG-HF clinical trial. So this is an RCT, and it looks like it's a little bit small here on the screen, but really what this main intervention was they took individuals who had been hospitalized with decompensated heart failure and swelling and edema, and they randomized them to placebo or high-dose empagliflozin at 25 milligrams a day. And then they asked very simple clinical questions. What happens with some of the ramifications? What is their clinical response? And do they have a safety signal? So the clinical response, as you can see, was the change in weight by day, and then the safety signal was the change in eGFR. So when we took a look at this manuscript, we thought this was very, very important, even though it was only single center. So when we think about impact, right, impact was clearly demonstrated because this was one of the only RCTs in medicine that has demonstrated superiority of one decompensated heart failure management strategy over another. Now, why also was it impactful? Well, this clearly motivated studies to hopefully determine scalability. As I mentioned, this was single center, but we could all see very readily how we could understand ways to better implement this into our own practice. And then clearly we felt that the results impacted clinical care. This was a novel treatment strategy for the management of heart failure. Now, when we talk about validity, as I mentioned, this was an RCT. This is placebo-controlled. The power calculations, as I mentioned on the last slide, were more than adequate. The endpoints were carefully measured, and they were accurately measured, and they described all these in the methods. There was careful follow-up, so patients were followed as almost completely till nobody was dropped off, nobody was lost to follow-up. And then, of course, the statistical analyses were appropriate and were very well done. So now I want to pivot to an observational cohort study. So Circulation is not restricted to just RCTs or giant population data sets. So again, I'm a heart failure doctor and I take care of a lot of patients with a disease called amyloidosis. So this paper is one of the favorite papers I've ever handled as an associate editor. This is an observational cohort study from the National Amyloid Center in the UK. So in the UK, this captures the national caseload of amyloidosis. So they have a really large catchment area. Now, you can see with their results, essentially what they're describing are different markers of prognosis, trajectories of biomarkers over time, and then we even see that genotype is associated with risk. And this was one of the first papers that demonstrated that the V122I mutation, which is a mutation in the transthyretin gene that is very common in individuals of African ancestry. So in the United States, we have 49 million people who have African ancestry. And so this is actually quite a prevalent mutation and is an important risk marker for the development of heart failure. So, and we saw that this was associated with a greater risk. So all of us really, really like this paper, but remember, impact is, it can be timely as well. So this came at a great time. So why did we feel that this analysis was impactful? So the first is that there was a very comprehensive assessment of outcomes. They knew what happened to everybody in their cohort study, and they had ways of tracking things like mortality, hospitalization. Embedded within their own clinical practice was routine and there were protocolized biomarker and quality of life measurements. So this easily translated to an observational cohort study. Now this information was critical because just several months before this manuscript was submitted, the United States FDA approved the first pharmacotherapy for transthyretin amyloidosis. And then as I mentioned, this was the first manuscript that really demonstrated the prognostic relevance of this variant to cause amyloidosis. Now, what about validity? This captured the national caseload in the UK, so we didn't have issues like selection bias that might have influenced these observations. As I said before, there was a standardized follow-up protocol, so there wasn't bias in patients that were followed more closely on one side and less closely on another. It was roughly equivalent. And then from a statistical standpoint, all of their analyses were appropriately adjusted. And then, as I mentioned, because this captured the national caseload of amyloidosis, this was far less biased than single center cohorts, and other institutions. So those are my slides, and hopefully this gave you a good example of some of the qualities and characteristics we look for in clinical papers. Again, I want to thank you all for your attention, and I look forward to all your questions.